Welcome to the program Overview of Alzheimer's Disease and Treatment. This program, as with all of my programs, is a literature review of the current state of therapy, and PharmCon always likes for me to say that I do not have any actual or potential conflicts of interest in the presentation of this topic. I would like to give a special acknowledgement to the late Dr. Ruth Coleman, who presented an Alzheimer's program for PharmCon in July of 2012, and I have used her presentation handout as a template in the development of this program. I think all of us have some idea of what Alzheimer's disease is, but simply stated, it's the most common form of dementia, and it represents about 60 to 80% of all dementia cases. Alzheimer's is characterized by increasing deficits in a patient's memory, their ability to think and reason, and by changes in behavior, all of which get continually worse over time. So who gets Alzheimer's disease? Just as with the definition of the disease, I think most of us have a fairly good idea of what an Alzheimer's patient looks like. The typical patient is an elderly patient, usually over 60 or 65 years old, although we will mention a little bit some early onset Alzheimer's, which can occur at much younger ages. This disease tends to run in families, so if you have a parent or a sibling with Alzheimer's, you're much more likely to develop Alzheimer's yourself, and if you have more than one first-degree relative with the disease, your risk is even higher. There are some specific genetic mutations that we'll talk more about later that will significantly increase the risk of developing Alzheimer's disease. And then there are other factors which are suspected but not proven to increase the risk of getting Alzheimer's, such as being female. This may be a function of the increased lifespan of females versus males, but there is some evidence that maybe women are more susceptible than men. Having a history of moderate to severe head trauma. So common things like an accident, like bumping your head, those types of things are considered mild trauma. But moderate to severe trauma would include the types of head injuries received by boxers. We have all seen Muhammad Ali and his condition. Football players, there's been a lot in the media lately about football players and repeated concussions and brain injuries and dementia later in life, and also combat veterans who come back from deployment with severe head injuries. And then having cardiovascular disease or its risk factors is also thought to increase the risk of Alzheimer's disease. These include things like increased blood pressure over a long period of time, having high cholesterol, diabetes, a history of smoking, past or present, and also obesity. And these are some of very few modifiable risk factors that are associated with Alzheimer's disease. The other risk factors that we'll talk about are really things that you inherit and that you can't do anything about. The term prevalence refers to the number of people who currently have a specific disease or condition. As of 2012, 5.4 million Americans are thought to have a diagnosis of Alzheimer's disease. Of those, 5.2 million are over the age of 65, while almost 250,000 or 200,000 patients with Alzheimer's disease are younger than age 65. Statistically, 1 in 8 Americans over 65 has Alzheimer's disease, and highlighting the fact that Alzheimer's disease increases with age, almost half, or 45% of Americans over age 85 have this diagnosis. As of the year 2012, the cost to care for these patients is estimated to be $200 billion per year. If prevalence is the number of people with the disease right now, incidence describes the number of new cases of a disease in a given time period. Currently, someone in the United States is diagnosed with Alzheimer's disease every 68 seconds. And with the aging of our population, this number is expected to increase to 1 person every 33 seconds by the year 2050. The table on this slide shows the number of new cases per 1,000 people for 4 different age groups. And again, it highlights the increasing incidence of Alzheimer's disease with age. So for the 65 to 74-year-old age group, there are 53 new cases of Alzheimer's per 1,000 people each year. As the age increases to the 75 to 84-year-old age group, the incidence increases to 170 cases per 1,000 people. At age over 85, the incidence is highest at 231 cases. There's some evidence that after age 90, the incidence of Alzheimer's disease levels off. This could be true, or this could just be due to the fact that since the average lifespan in the United States is around 78 years, that we have very little data for this age group of 90 and above. And the author of one article that I read in preparing for this program even suggested that if we lived long enough, say to age 120, we might all develop Alzheimer's disease. As I think we're all aware, Alzheimer's disease is associated with significant morbidity and mortality. Currently, it's the 6th leading cause of death in the United States and the 5th leading cause of death among people aged 65 and older. Alzheimer's patients frequently die from pneumonia, brought on by their lack of mobility and swallowing difficulties. Population attributable risk is a statistical measure that represents the number of deaths that could be prevented if a certain disease were eliminated. So for Alzheimer's disease, this risk is calculated to be 5 to 15% over 5 years in patients 65 and older. So in other words, 5 to 15% of deaths in this population can be attributed to Alzheimer's disease. Patients that are living with Alzheimer's disease are living with a slow and insidious disease. Most patients with Alzheimer's survive for an average of 4 to 8 years past their diagnosis, and almost half of that time is spent in the most severe and debilitating stages of the disease. As for the diagnosis of Alzheimer's disease, a definitive diagnosis cannot really be made until after death because you have to look at the brain and to see if there are those hallmark changes known to be associated with Alzheimer's disease. And we'll talk some about those in just a few minutes. But short of that, doctors can assess a patient's overall health and their behavior changes. They can test things like memory and language, problem-solving skills, and they can also perform other diagnostic tests like MRI and CT scans to look for those Alzheimer's-type brain changes or to find some other cause for the dementia other than Alzheimer's. In 2011, the National Institute on Aging and the Alzheimer's Association recommended new diagnostic criteria for Alzheimer's disease. Many of the things stayed the same, but most notably, the new criteria proposed that Alzheimer's disease begins many years before the signs and symptoms begin to affect daily living, and that new technologies like MRI and CT scans and PET scans may have the potential to identify Alzheimer's-related brain changes that occur before the disease can be detected by a patient's behavior. Although these things are still investigational, these new technologies do include the use of MRI, PET scans, CT scans, as well as testing the blood or cerebrospinal fluid for certain proteins that are known to be associated with Alzheimer's disease. As I mentioned earlier, there are two types of Alzheimer's disease. There's early onset Alzheimer's and late onset Alzheimer's. Early onset Alzheimer's is when symptoms appear before age 60. This type of Alzheimer's is much less common than the late onset, but it also tends to be more aggressive and progress more quickly. Early onset disease is also known to run in families, and there have been several genes identified that can cause this type of Alzheimer's. It's often referred to as familial Alzheimer's disease, abbreviated FAD. And then late onset Alzheimer's disease is the most common type, and that's the type that occurs in people age 60 and older. The course and progression of this type is less aggressive than for the familial, and although it may run in families, the role of genes is less clear for the late onset Alzheimer's disease than for early onset. And you sometimes will see this type of Alzheimer's disease referred to as sporadic Alzheimer's disease, abbreviated SAD, to sort of distinguish it from the familial Alzheimer's disease. Alzheimer's disease can also be divided into stages, and the 3 stages I have shown here are as they were defined in the new 2011 diagnostic criteria. And the first stage is the preclinical Alzheimer's, where there can be measurable brain or CSF changes, but there are no symptoms that are affecting the patient. It's estimated that these changes can start to occur up to 20 years before symptoms can be seen. And currently, there is no way to diagnose this stage, but it's thought that in the future, we will be able to use new technologies and new tests to diagnose this pre-symptomatic stage of Alzheimer's. The second stage is mild cognitive impairment, where there are small but measurable changes in a person's ability to think and in their memory. They're noticeable, but they're not severe enough to affect their everyday living. It's estimated that 10 to 20% of people over 65 will have mild cognitive impairment, but it's important to remember that not everyone who has mild cognitive impairment will go on to develop Alzheimer's disease. But if there is evidence that Alzheimer's disease is present, then the patient would receive a diagnosis of mild cognitive impairment due to Alzheimer's. And then the final stage is Alzheimer's dementia, which we typically think of as Alzheimer's disease. This is where the changes in memory, thinking, and behavior are severe enough to affect daily living, and then the disease becomes progressively worse over time from this point. So let's take a look at these behavioral symptoms of Alzheimer's disease using the Alzheimer's Association 10 warning signs of Alzheimer's. But so that you will not all think that you have Alzheimer's disease by the time we finish going through these two slides, I'm going to give examples of normal behavior and abnormal behavior that would be a warning sign of aging. So number one, memory loss that affects daily living. Okay, normally we all forget things. You would forget an appointment, you forgot to go to the doctor, but you remembered it later. That's normal. A warning sign would be forgetting dates and events and things, especially things that you've learned recently, and for asking for the same information over and over. It's that inability to sort of form a new memory that's a warning sign. Number two is challenges in planning or problem solving. So a normal challenge would be making an error balancing your checkbook. Everybody makes a math error. We all do that. A warning sign would be not being able to pay your bills at all, being so completely overwhelmed by that that you didn't get any bills paid, or not being able to follow a recipe that you've always made, something you're familiar with, and now you're not able to do it anymore. Number three is difficulty completing familiar tasks. So I would like for you to type in the chat box now if you do not know how, and you do not have plans to know how, to set a DVR. Because I don't know how, I just call a small person at my house and they come do it for me. So the fact that I don't know how to operate a DVR is normal for me. But if I had ever known how to operate the DVR and all of a sudden I couldn't do it, that would be a warning sign. Other things would be trouble driving to a familiar place, someplace you should know where it is, but all of a sudden you can't get there. Or remembering the rules to a game that you've always played. If you and your partners have played canasta for 20 years and all of a sudden you can't remember the rules to canasta, that's a warning sign. Number four is confusion with time or place. We all get the days of the week mixed up. That's normal. You go through all of Tuesday thinking it's Wednesday, but then at the end of Tuesday you remember. A warning sign, however, is losing track of complete passages of time. Things like forgetting where you are or knowing how you got there. Losing your car in the parking lot at the mall is not uncommon, but walking out of the mall and not remembering how you got there is a warning sign. And then number five is difficulty with visual images or spatial relationships. So normal signs of aging are developing cataracts or having trouble seeing at night. Many older people don't like to drive after dark because they have trouble seeing, and that's normal. But if you're having trouble with visual and spatial relationships, if you're driving your car in the daytime and you can no longer judge the distance between your car and the car in front of you or between your car and the stop sign, then that is a warning sign and is cause for significant concern while you're driving. Number six is problems with words, speaking, or writing. So it's normal in the course of a conversation to have trouble finding the right word that you're looking for, or you're trying to think of a name. Who is that guy, that person you know? We all do that. That's normal. But a warning sign is when that kind of thing happens to the degree that you're not able to carry on a conversation, or that you can't recall common words even after thinking about them. You can't think of the word for watch, so you just say, what time is it there on your hand clock? So you make up these funny words. Those kinds of things are warning signs. Number seven, misplacing items and not being able to retrace your steps to find them. Okay, I'm fairly certain that my van keys and house keys are out in my garage somewhere. They've been there for months. and if I would just go clean up the garage, I'll probably find them. But at least I know where to start looking. That's normal, to lose things. We all lose and misplace stuff. But a warning sign is when you misplace things and you have no idea where you've been to even go back and look for them. So when Alzheimer's patients can't find their stuff and they don't remember having been somewhere where they could have lost it, then it's common for them to start accusing other people of stealing their things. Those are warning signs. Number 8, decreased or poor judgment. So it's normal for us all to make a bad decision once in a while. We all spend some money we shouldn't have spent, or we go out and we do something we shouldn't have done. That's normal. But when it happens frequently, and you're frequently making poor decisions, or you're frequently doing things you wouldn't normally do, you're giving away money, or you're giving large sums of money to telemarketers or evangelists, or you're being taken in by scam artists, things you wouldn't have done maybe 10 years ago, and now you're doing them frequently, that's a warning sign. Number 9 is withdrawal from work or social activities. So it's normal for us to all feel like not going out. Everybody gets tired. Sometimes we just want to stay home. Maybe we want to have a mental health day. Those things are normal. But if you begin avoiding social activities on a regular basis because of these changes in your mood and behavior, because you can't carry on conversations easily anymore, then that's a warning sign. Other things might include not being able to keep up with your favorite sports team because you can't remember, what happened in the game yesterday, or not being able to play a favorite game anymore that keeps you out of social activity because you can't remember how to play the game. And then finally, number 10 is changes in mood and personality. It's normal for all of us to be irritable sometimes. It's normal for elderly people to be irritable when their schedules are messed up, right? Like, I've done it this way for the last 20 years, and this is the way we do it. And if you mess that up, then that gets people a little out of whack. But a warning sign is kind of going past irritable. If they're out of their comfort zone and they're no longer irritated, but maybe they're angry or combative, or they become more confused, or they're suspicious of others, someone's trying to harm them, those types of things are warning signs. So those are our 10 warning signs of Alzheimer's from the Alzheimer's Association. I hope you all survived that and everybody's feeling relatively good about themselves at the end. Okay, I have one more slide here in reference to the disease itself before we move on to etiology, and that is the progression of Alzheimer's. Once we have the disease and that diagnosis has been made, what happens from there? And as we said before, it's a slow disease that progressively gets worse, and it's kind of runs on a continuum from mild to moderate, moderate to severe, and severe. It's a sort of a continuum of symptoms. But in the milder stages, we have these changes in sleep patterns, which often means they're awake at night. Sort of roaming, you have that sundowner syndrome where they get really confused in the evening and they may be up and down all night. You have those behavioral changes that we've talked about in the last 2 slides. The forgetfulness, forgetting basic things like the memories of your life or who you are. And I think, again, often you'll find that they forget recent things before they forget distant memories. Like your grandmother may remember who her 2nd grade teacher is, but she can't remember if she had lunch today, those types of things. And then the difficulty in speaking that we've talked about before, difficulty carrying on conversations or talking in confusing sentences. As the disease progresses on towards severe, in the final stages, these patients can no longer speak. They may just make little grunts or moans, but no speaking at all. They don't recognize friends or family. They may look at you, but they really have no idea who you are. They get to where they can't do any activities of daily living by themselves. They can't eat, they can't dress, they can't bathe, they can't toilet themselves. They're completely dependent on others for their care. And then they also develop swallowing difficulties, which is the most concerning at this stage because that leads, first of all, to malnutrition. They start losing a lot of weight, kind of waste away, they get really tiny. And then, as we've mentioned before, that also leads to a risk of aspiration, which can lead to pneumonia, which is one of the big causes of death among Alzheimer's disease patients. So let's take a look at the etiology of Alzheimer's. What is causing this disease? While the etiology is largely unknown, it's thought that it's probably a result of many factors rather than just one factor, and we have some bits and pieces that we know, but we're still trying to put it all together. However, there are two proteins that are credited with playing a crucial role in the development of Alzheimer's, and they are beta amyloid and tau. Beta amyloid accumulates outside of the neuron, and tau protein accumulates to cause neurofibrillary tangles inside of the neuron, which then causes the neurons to die. The role of beta amyloid in the etiology of Alzheimer's disease is often referred to as the beta amyloid cascade or the beta amyloid hypothesis. This hypothesis begins with the transmembrane protein amyloid precursor protein, or APP. In a healthy brain, APP is cleaved after translation by two enzymes. First by alpha secretase, which is represented by green in the figure, and then by gamma secretase, which is represented in this figure in blue. And this creates two protein fragments that you see, sort of one above and one kind of down in the membrane. The longer of the two fragments produced in this process is 40 amino acids long, and it's thought that this fragment is neuroprotective and beneficial to the health of the brain. In an Alzheimer's brain, the amyloid precursor protein is first cleaved by beta secretase instead of alpha secretase, and then by gamma secretase. The longer of the two fragments produced in this process is 42 amino acids long instead of the normal 40 amino acids long. So these 42 amino acid fragments clump together and become insoluble, forming the beta amyloid plaques. Beta amyloid plaques are known to be present in the brains of patients with Alzheimer's disease, but the presence of beta amyloid plaques does not correlate well with neuron loss or dementia, and it's this fact that has led to some debate about beta amyloid's role in the development of Alzheimer's disease. Even though there may be debate, there is also substantial genetic evidence to support the beta amyloid hypothesis. For example, about 1% of Alzheimer's cases are due to one of three known genetic mutations that affect the levels of beta amyloid in the brain. You can have mutations in the gene responsible for the production or processing of amyloid precursor protein, that APP. This gene occurs on chromosome 21, the same chromosome that's affected by Down syndrome, and it's known that some Down syndrome patients develop an early onset type of dementia that's similar to Alzheimer's disease. There are also known mutations in the genes that code for presenilin 1 and 2. So shown here in yellow in the figure, presenilin 1 and 2 are proteins that help form the active site on that gamma secretase enzyme that cleaves APP. Mutations in the genes that code for presenilin 1 and presenilin 2 ultimately result in an increased production of that 42 amino acid amyloid fragment, which then clumps together to cause the beta amyloid plaques. Having any one of these three mutations guarantees that a patient will develop Alzheimer's disease, usually before the age of 65 and even as young as the age of 30. Having a mutation in the gene that codes for presenilin 1 accounts for about 70% of genetic Alzheimer's cases, and a mutation in the gene that codes for presenilin 2 accounts for about 20% of those cases. Further support for the beta amyloid hypothesis can also be found in the apolipoprotein E gene, or ApoE. You're probably most familiar with ApoE protein as part of the VLDL molecule that carries excess cholesterol from the bloodstream back to the liver for processing. But ApoE also plays a role in the nervous system development as well as aids in repairing the nervous system after head trauma. There are three major alleles or versions of the ApoE gene, and they're named ApoE2, ApoE3, and ApoE4. And having the ApoE4 allele has been associated with increased beta amyloid plaque formation and an increased risk for developing Alzheimer's disease. Now, unlike having one of the three known genetic mutations that we talked about on the previous slides, having the ApoE4 allele does not guarantee the development of Alzheimer's, but only increases the risk. Each person has two ApoE alleles, one copy from mom and one copy from dad. ApoE3 is the most common allele, and it carries about a 10% risk of developing Alzheimer's disease by age 85. In contrast, inheriting one ApoE4 gene increases the risk to about 30%, while having two copies of that gene doubles the risk to around 60%. It's also been found that inheriting the ApoE2 allele may be neuroprotective and could promote a healthier aging in those with one or more copies of this gene. The other major protein associated with Alzheimer's disease is tau. In healthy neurons, tau protein helps to stabilize the microtubules, shown in the figure here, which transport nutrients and neurotransmitters within the neuron. Tau is normally phosphorylated, but in Alzheimer's disease, the protein becomes phosphorylated in many more sites than usual. This is something that's referred to as hyperphosphorylation. This causes the protein to fall away from the microtubules in string-like structures called threads. These threads then combine into helical filaments to form the neurofibrillary tangles associated with Alzheimer's disease. When the microtubules disintegrate, the ability of the neuron to transmit information is also disrupted, and the neuron dies. Another question in Alzheimer's research is how are beta amyloid and tau related? We know that beta amyloid plaques and tau tangles, which are represented in this figure as paired helical filaments, or PHF, sort of at the bottom half of the figure, we know that they're both found in the brains of patients with Alzheimer's disease. It's also known that beta amyloid can begin to accumulate in the brain years before any signs and symptoms of Alzheimer's disease are present, and that there's no good correlation between the presence of beta amyloid plaques and the development or presence of dementia. In fact, beta amyloid plaques can be present in the brains of individuals who never develop Alzheimer's disease. There's a much clearer association between the presence of tau tangles, neuron death, and dementia. Patients with Alzheimer's disease have these neurofibrillary tangles, and it's thought that they form close to the time that signs and symptoms begin to appear. So the trouble is that the exact relationship between these two events, the formation of beta amyloid plaque and the development of neurofibrillary tangles, is not completely understood. And as you can see in the figure, the authors here represent whatever that relationship may be simply as aggregate stress. So what can be done about Alzheimer's disease? The standard of treatment involves both pharmacologic care and supportive care for both the patient and the caregivers or the patient's family. But currently, our pharmacologic treatment is very limited. Although Alzheimer's disease has been described for over 100 years, we only have 4 drugs approved on the U.S. market to treat Alzheimer's disease, and these 4 drugs can only treat the symptoms of the disease. There are no disease-modifying therapies available that can change the course of the disease, treat the underlying cause of the disease, or reverse the disease. There are 2 classes of drugs used to treat Alzheimer's disease. One is the acetylcholinesterase inhibitors, which include donepezil, rivastigmine, and galantamine. Since in Alzheimer's disease we have these dying neurons in the brain, we have decreased levels of neurotransmitters, and these drugs help to alleviate the symptoms of Alzheimer's disease by increasing the levels of the neurotransmitter acetylcholine in the brain. The first drug in this class is donepezil, which has been marketed as Aricept and Aricept ODT. Because of the side effect profile of these drugs, all of the drugs in this class have a titration schedule. So the starting dose for donepezil is 5 milligrams given at bedtime. That dose can be increased to 10 milligrams given at bedtime after at least 4 to 6 weeks at the 5 milligram dose. And then the 10 milligram dose can be increased to 23 milligrams at bedtime after at least 3 months on the 10 milligram dose. The 5 to 10 milligram dosing is used to treat mild to moderate Alzheimer's disease, and the 10 to 23 milligram dosing is used for moderate to severe Alzheimer's disease. Donepezil was approved in 1996, so it's been on the market long enough that all forms are available in generic, which makes it a cost-effective treatment option. The second drug approved in this class is rivastigmine, which was approved in the year 2000 and marketed as Exelon, and more recently as Exelon patch. Again, doses are started low and titrated upward to a target of 6 to 12 milligrams per day. When using the capsules, the titration interval is 2 weeks, but it's 4 weeks for using the patches. Rivastigmine carries a formal indication for dementia related to Alzheimer's disease, but also for dementia associated with Parkinson's disease, which makes it a little bit different than the indication that for other drugs in this same class. The capsules are available in generic, so this also makes it a cost-effective option, but you'll notice it has to be given twice a day, which is less convenient than the once-a-day option with donepezil. The third and final drug in this class is galantamine, which was approved in 2001. And this was a drug you may remember was first marketed under the brand name Rimonil, but that name sounded too much like Amaryl. So the name was later changed to Razidine, and now we had Razidine and Razidine ER, but they've been on the market long enough that all of these formulations are now available in generic. Again, we start with low doses and titrate up. For both dosage formulations, the titration interval is 4 weeks. So for the BID formulation, you start at 4 milligrams and titrate every 4 weeks up to 12 milligrams, and even as high as 16 to 32 milligrams have been used. With the extended release formulation, you start at 8 milligrams and titrate every 4 weeks up to 16 to 24 milligrams a day with that formulation. Again, the extended release formulation is probably a little bit more convenient. It's available in generic, so it's cost effective, and it is just that once a day dosing, which makes it much more convenient for people. As a class, these drugs have very common side effect, drug interaction, and precaution profiles, so I'm just going to cover them all together. But with this class of drugs, the main side effect and the main problem we experience is nausea, vomiting, diarrhea, which leads to anorexia and weight loss. So this is really the main reason for the titration of those doses. Because of that severe stomach upset. And again, you don't want Alzheimer's patients throwing up because we may have swallowing difficulties already, and we have that risk of aspiration and then the development of pneumonia. So we have to titrate, and we have to watch these people to look out for those specific side effects. Other side effects that can be seen from using these cholinergic drugs are muscle cramps, insomnia and fatigue, also headache and dizziness. So those are the main ones. Everything else occurs in small percentages, but these are the big ones. There are several precautions to consider when using acetylcholinesterase inhibitors in Alzheimer's patients. First, urinary precautions. Acetylcholinesterase inhibitors can cause urinary retention or bladder obstruction, so you need to look out for that. With pulmonary patients with a history of asthma or COPD, acetylcholinesterase inhibitors can increase bronchoconstriction and increase those bronchial secretions, so we need to look out for that. Cardiovascular concerns, acetylcholinesterase inhibitors can slow the heart rate, causing bradycardia or heart blocks. You need to look out for patients that could be susceptible to that. Neurologically, these drugs can have the potential to cause generalized seizures, and Alzheimer's disease itself has the potential to cause seizures. So using these drugs can sometimes potentiate that seizure possibility. Gastrointestinal effects, we've already talked about the nausea, vomiting, diarrhea that can occur, but these drugs can also increase the risk of peptic ulcers, so you need to be careful with patients who have a history of that. And then the final two on here, renal and hepatic considerations, are most specific to galantamine. So if there is moderate renal impairment or moderate hepatic impairment, the dosing should not go beyond 16 milligrams per day for galantamine. And then it's recommended if there is severe impairment of either of these systems, renal or hepatic, that you not use this drug, that you choose something else. Common drug interactions among this class include cholinergic medications. The one that's always listed and highlighted is succinylcholine, because using acetylcholinesterase inhibitors along with succinylcholine may potentiate the muscle relaxation when succinylcholine is used in anesthesia. So that's a consideration if your patient is having to have surgery. Of course, anticholinergics, they're going to work opposite each other. Oxybutynin and tolterodine are the two that are commonly cited as possibly working opposite of each other if they're given. The two drugs could cancel their effects out. Antipsychotic medications, use of these acetylcholinesterase inhibitors can increase the effects of many antipsychotic medications that might be used to treat other underlying conditions with these Alzheimer's patients. So the antipsychotic medications are usually used in small doses to account for that. Beta blockers, because beta blockers also slow the heart rate, and we said on the previous slide the acetylcholinesterase inhibitors can slow the heart rate, so you need to be careful if you have two of those combined. And then the NSAIDs, because of the gastrointestinal upset and the increased risk of peptic ulcers, NSAIDs could potentiate both of those things. There are also a few drug interactions that seem to be specific to galantamine, and that is when galantamine is used in combination with certain antidepressants. The ones generally mentioned are amitriptyline, fluoxetine, and paroxetine, although many of the SSRIs could probably be included in this category. But the problem with these three is that they're potent inhibitors of the cytochrome P450 2D6 enzyme, and the 2D6 enzyme is a primary enzyme involved in the metabolism of galantamine. So if these antidepressants are used, the bioavailability of galantamine can be drastically increased, which is going to increase side effects, which is going to increase, nausea, vomiting, diarrhea, all of the things we're trying to avoid in these patients. It can be increased as much as 40%, so that's pretty significant. Citalopram and S-citalopram don't seem to interact with the 2D6 enzyme. They're not as potent of an inhibitor, and so they could be good recommendations of SSRIs if an antidepressant is needed. There's a potential for this same type of interaction with donepezil, although it's not really documented very well in the literature. It's one of those could happen things, but doesn't really seem to happen that much. And then ribostigmine actually does not undergo metabolism very extensively by 2D6, so there would not be an interaction with SSRIs and ribostigmine in this case. The other class of drugs that we have to treat Alzheimer's disease symptoms is the NMDA receptor antagonist. The only drug in this class is memantine, and it's marketed as Namenda and Namenda XR, and this drug is approved and indicated to treat moderate to severe Alzheimer's. It's thought that overstimulation of the NMDA receptors by glutamate contributes to Alzheimer's disease symptoms, so these drugs block the NMDA receptors in the brain to help treat those symptoms. Again, there's no evidence that this treats the underlying causes of Alzheimer's disease or that it even stops the progression of the disease, but it does help to treat the symptoms. As with the acetylcholinesterase inhibitors, dosing of memantine has to be started low and titrated upward so that we can minimize side effects. So for the original Namenda BID formulation, the dosing begins at 5 milligrams per day, and then at 1 week intervals, it's increased to 5 milligrams BID, and then 5 milligrams once a day, alternating with a 10 milligram also once a day, and then finally to the target dose of 10 milligrams BID. For the XR formulation, the titration is started at 7 milligrams once daily and then increased at 1 week intervals to 14 milligrams, 21 milligrams, and then to the target dose of 28 milligrams. There are titration packs available for patients to get started on these medications, so you don't have to have all these separate scripts. But currently, these are only available as brand names. There are no generics marketed. The best I can tell, the first generics of Namenda or generic memantine should be on the market in early 2015. So we have a couple of more years before we'll be able to see these in generic. The most common side effects of memantine are headache, dizziness, and diarrhea. You can also see some vomiting with this drug, but typically the big three that are cited are headache, dizziness, and diarrhea. Common cardiovascular side effects such as hypertension, hypotension, and syncope can also occur. Again, with this drug, we have the seizure issue. Alzheimer's disease can cause seizures. There's the potential this drug could cause seizures, so there's a potential those things could be potentiated. Again, it's one of those things that's a possibility, but it's not well documented, and some of the clinical trials actually showed that the seizure potential was less for patients who were on memantine than for patients who were on placebo. So it's a consideration, but it doesn't seem to be a huge one. Precautions when using memantine, again, include urinary precautions, but this time for a different reason. Anything that can increase urinary pH, any drugs, any disease states, any nutritional issues that can increase urinary pH will they'll decrease the elimination of memantine and then increase the side effects. So those are things to watch out for. Severe hepatic impairment, mild to moderate impairment is okay. But it's recommended to use caution in severe hepatic impairment, and although there are no dosing recommendations given. And then for severe renal impairment, which is defined as a creatinine clearance of 5 to 29, The target dose should be reduced to 14 milligrams per day for the XR formulation and 5 milligrams BID for the regular Namenda BID formulation. Some common drug interactions when using memantine. Other NMD receptor antagonists. Ones generally listed are amantadine, ketamine, or dextromethorphan. And the literature will say that these interactions have not been investigated, they've not been evaluated thoroughly, but there's the possibility that using these along with the NMDA receptor for Alzheimer's could potentiate the side effects. So it's possibility, not well documented. Urinary alkalinizers, that goes back to anything that increases urinary pH is going to decrease the elimination of this drug and increase the side effects. If the pH is raised to 8, it can actually reduce the clearance of memantine by 80%. So this is a significant concern to look out for any drugs that increase urinary pH as well as health conditions or dietary issues that a patient has. In addition to treating the Alzheimer's symptoms, it's also necessary to treat any coexisting conditions that these patients might have. So some common things you would see are anticonvulsants. Again, Alzheimer's disease can cause seizures. Some of these medications have a potential to cause seizures. So some common anticonvulsants you might see are carbamazepine or phenytoin. Antipsychotics you'll see for that agitation and aggressive behavior that we talked about in the signs and symptoms. So some common examples of these are maybe haloperidol, olanzapine, quetiapine, or risperidone, any of those. But again, remember they're going to be used at lower doses because the acetylcholinesterase inhibitors used for Alzheimer's disease can increase the side effects of these medications. We talked about antidepressants. Again, citalopram and escitalopram are good choices because there's less of a potential that they'll interact with other medications. You want to avoid any prescription or over-the-counter medications that make confusion worse. Stuff that makes confusion worse, narcotic pain medications, cough syrups with narcotics in them, antihistamines, or prescription sleeping medications. You know, antihistamines are what's in the over-the-counter sleeping medications. People will think that they're safe to use because they're over-the-counter. They're not really great choices for elderly people with any kind of condition, especially Alzheimer's. And even the prescription stuff you may have to give up if it makes the confusion worse. And you also want to avoid any prescription or over-the-counter medications that have excessive anticholinergic side effects. In addition to pharmacologic care for an Alzheimer's patient, a large part of the care of these patients is offering support to both the patient and the caregiver. According to the Alzheimer's Association, 15 million Americans provide unpaid care for a person with Alzheimer's disease or some other form of dementia. And 80% of home care for Alzheimer's patients is provided by a family member. If you're ever taking care of one of these patients, you know this job requires constant attention to the patient and it can become exhausting for the caregiver, especially if there's no one to offer some occasional relief for them. Examples of supportive care can include coordination of the patient's care among the physicians and other healthcare providers and the family members, participation in activities and adult daycare programs for the patient to give the patient some social interaction and to give the caregiver a break, and then taking part in support groups and supportive services such as counseling, again, for both the patient and maybe even more importantly, for the caregiver who is taking care of the patient. My mother-in-law occasionally keeps her 92-year-old mother who suffers from dementia in her home for short periods of time. And Nana will wander around the house. She's up all hours of the night. My mother-in-law sleeps in a room with her bed by the door so she can tell if she's getting out of the room. And she can get in and out of situations that you would never think that she could. One day they couldn't find her. They were looking for her. They didn't know where she was. When they finally found her, she was sitting in the car in the driveway waiting to go somewhere. So this is a full-time job to care for one of these people and keep them safe, and it can really be exhausting. Another frightening statistic offered by the Alzheimer's Association is that about 800,000 people with Alzheimer's live alone. There's no one to look after them, to keep them safe, and to keep them from wandering. The Alzheimer's Association 2012 Facts and Figures publication actually includes a special report on these patients who are living alone and tries to address ways that care can be provided for them. Finally, as pharmacists, we can offer counseling and support to Alzheimer's patients and to their caregivers. Our greatest asset as pharmacists is our drug knowledge. So we can help educate patients and caregivers about the side effects of these drugs that they're taking to treat their symptoms and help them understand the titration schedules and the reasons that they need to titrate these medications. We can help them understand drug interactions and why they shouldn't take an over-the-counter sleeping aid, things like that we can talk to them about. We can also help monitor adherence to drug therapy in these patients. Many retail pharmacies are becoming more and more involved with MTMs, those medication therapy management services. So we can run reports or we can check profiles to see if patients are refilling their medications at proper intervals. And this gives us an indication if they're taking their medications properly. We can also recommend services like automatic refilling so that medications are refilled and patients are contacted when they're ready to pick up. So that might take a little bit of burden off of a caregiver who would have to remember to do those things. Many pharmacists are vaccinators now, so we can offer vaccines for flu and in some cases for shingles and pneumococcal disease to help keep these patients and their caregivers well. A caregiver can't take care of someone else if they're sick with the flu, so it would be helpful if we offer these services to them and make them aware that we have them at the pharmacy. And finally, we can offer support to them just simply in our interactions with them at the pharmacy. Many people like to talk when they come to the pharmacy. So pharmacists and technicians can support these people by taking a little time to listen and to chat. And for a caregiver, you might be the only good conversation that they have that day. We can also help them find local support groups and care groups in your community that could help them with the caregiver support and with respite care so they can get away a little bit, and with social interactions for the patient who has Alzheimer's as well.